So, my name is Dr. Nate Estrin, and this is Dr. Michael Kanter, and he is the guy that taught me how to do sutureless free gingival grafting with periacral only. So I've been using that technique alone for 3 years, and it has been probably the most invaluable clinical pearl in my practice to date, especially when we use it with PRF and all the other procedures we do with PRF. But that has been a total game changer for me in terms of cutting down the time it takes to do a procedure, and also it's incredibly successful. I haven't had a failure to date with it. It's more successful than implants.
When I first started doing these, PRF wasn't around, I don't think. I don't know what took Dr. Myron so long to bring it to us.
Yeah.
On the palate, we would just put some hemostatic gauze in place there. And it would be the most uncomfortable thing for the patient. But now, being able to put some PRF there and suture that over the site just accelerates that healing a lot.
Yeah.
And we also can, of course, soak the donor piece.
And even that has become sutureless.
Yeah.
So I used to suture the solid PRF to the palate.
Right.
And then just a quick shout out to Dr. Lauren Anderson, who taught me this technique. I did an in-office training with him in his office in Washington, and he would put the solid PRF alone, then place the stent in, and the solid PRF would become incorporated into the patient's blood clot, and it would stay there, and it wouldn't move. And now 1 week post-op, you see the patient, and the solid PRF is still there. So, you know, it's become completely sutureless. The palate, the donor site, and the recipient site, sutureless. It's incredibly fast.
Well, the suture companies might not like that.
Yeah. Sorry, Salvin.
But the whole procedure and technique, you get such good results.
Yeah.
And I mean, you really save a lot. The most recent one that I did with Dr. Estrin, when he harvested the donor piece from a previous graft that I had done 15 or 20 years ago, because you know they always seem to thicken up a lot over a long period of time. And so he took Dr. Estrin took the donor piece by harvesting it from the original free gingival graft that was done on the contralateral side. And it was so much faster and so much easier, and the patient really liked it a lot because they still remember taking it from the palate.
Yeah. And that was an awesome moment, you know, just a graft that you had done 15 years prior, you know, and now we're doing it together and using the previous graft, you know, 15
Right.
years later to create a new recipient site on the other side. So that was really just cool.
And the patient, when the patient got up, he said, "Man, that sure was a lot easier."
Yeah. You scarred them 15 years ago.
You know, and one problem is if they do need it bilateral procedures, I like to do one side at a time because I want them to have one side to eat on and not dislodge the donor piece from the recipient site. And so sometimes you would do one side and tell them that after it's healed up and all that, down the road we'll do the other side. Well, when you take it from the palate, they don't want to come back and do the other side because that's so miserable.
Yeah.
It was really nice being able to use that original site to do the contralateral side, and that also patients, they have not complained to me about how the grafts thicken up, but you notice that when you do it, and then over many years, 15 years later, so you see the graft's much thicker. Mm-hmm. And the patients don't complain about it, and it works fantastic. But it was really nice being able to use that to take a new piece for the other free gingival graft, and then also, then that thins out the original one, so it's thin again.
Yeah, so it's thin again. There you go. And I'm sure that helps with case acceptance because you tell them, hey, we don't have to take from your palate this time. We can take from the previous grafted site.
Yeah, a lot. I had people. That's the thing. Like I said, I don't like to do bilaterally at one visit because they won't have a good side to chew on, and then a lot of times they didn't want to come back. And but when you tell them now that you don't have to take it from the palate next time, or something like that, this patient really loved it that we just did. We didn't have to do that.
Yeah. And if you do take from both sides, that's where PRF comes in handy.
Yeah.
For just a faster recovery. You know, obviously we know it helps with soft tissue healing. So
Well, the PRF just works better with everything.
everything. Yeah.
And I just originally, it just wasn't around when I started doing these.
Yeah.
But you can definitely see a big difference, especially on the healing on the palate.
Yeah. Or if you soak, you know, rather than hydrating the graft in saline or epinephrine, which could cause vasoconstriction, you soak it in liquid PRF and you pull it up and you see a nice blood clot on the intaglial surface of the graft, and you know you're expediting healing because you've got a super clot with a super physiological dose of growth factors there.
Yeah, the PRF has just brought the whole procedure just a big leap forward.
Yeah,
You know?
yeah, absolutely. Took an already fantastic technique and perfected it really.
Yeah, and we just keep using the PR for more and more stuff.
Yeah.
I mean, you know, implants, extractions, sockets, basically any surgical procedure you do intraorally, if you add PRF to it, you just get a faster, more complete, you know, more mature.
I heard you drink it too. Someone told me you drink it.
Only on the weekends.
Only after a long day of work.
Yeah.
I remember when you first taught me the technique. I think it was my first week out of residency, and I'm practicing here, and suturing a free gingival graft and suturing a free gingival graft, and you lean your head in, you know, and took a peek, and you said, "Boy, you periodonters sure like to do a whole lot of extra work for nothing." And I was like, "What do you mean? You know, what are you talking about?" And I didn't believe you at first, and then I saw you do one in about maybe a fourth of the time that it took me to do the technique with suturing, and the rest is history.
And also when you're harvesting the graft, I was like, boy, you guys do it the hard way. You know?
Yeah.
And
so it's been great. You know, I came here, never thought I would change my technique on free gingival graft because it's one of the more predictable procedures that we do in perio. You know, but to make it faster and easier, less technique sensitive, it's just really helped me increase my production in clinic and make patients happier. You know, I love when they get up from the chair and they go, "That's it." You know, you feel like you're cheating a little bit without the sutures.
Using that periacral on that superior border, and when you're doing it without the sutures and you're just using the periacral to cement the graft into the recipient site, and you're putting the first thing I do is I put some of that tissue cement on the superior border, and sometimes I'll use it on the lateral a little bit if there's some immobile tissue, and sometimes I don't. The main thing when you're putting it on that, especially on the superior border, make sure that the donor piece of tissue is all the way against the recipient site. You don't want a gap under there where the periacral is going to get underneath the
That's a good point.
underneath the graft, and then you're not going to get any angiogenesis up in there. That's going to separate from getting some blood vessels growing up from the periosteum and the connective tissue underneath. So make sure that the superior border of the graft is firmly, against the recipient tissue, and so when you put that tissue cement on there, it's not leaking through.
I think I had a case like that actually, where the periacral did drop a little bit underneath the graft, but I thought it would be okay, and I put the copac on, and the graft was still successful, but there was like a little pocket that you can probe. So it's definitely a good idea. Make sure there's no periacral underneath the graft.
Well, that's a good spot for them to store their chewing tobacco and stuff like that.
Yeah,
it's
a good place to keep your crumbs.
Yeah. I usually, and I tell them with the copac that we put on, I tell them, we like to leave it on 2 weeks if it will. And I tell them sometimes it'll come off early. And if it does, I tell them just really baby it. Don't rinse, don't brush, don't do anything. And I'll tell them if it comes off within the first week or something, I want to call the office and come in. But if it comes off more towards the end, I tell them just don't baby it. I mean, just don't rinse vigorously in there. Stay away from it. Don't eat around there. Just leave it alone and really baby it, and it should be fine.
Yeah.
And I've never had an issue.
I had one case where we do the procedure. I apply the free gingival graft, periacral, and I'm ready for the co-pack, and we're out of co-pack in the office. What do you do then, right? So we let the patient go, and we did it. We actually did it bilaterally. Mandibular premolars on each side, 2021, 2029, and it worked without co-pack. And I don't know if I have the balls to do that again, but it worked. So, and I explain it to patients and other clinicians. It's like when you get tissue glue or super glue on your fingers and it's hard to get
Right.
off. It's essentially the same thing as super glue, right? So when you use periacral to fixate a free gingival graft, it's just like, really adheres to the site, and it's when you're moving the lip and you're checking for any movement of the graft, it's more stable than if I did sutures.
I think it is super glue, and they just repackaged it so they can charge more.
So they can charge more, probably. Yeah. I don't know if I have the balls to buy super glue and use that on patients either, though.
No, but it's very similar. That's
Very
for sure.
similar. Yeah. Very similar.
How long do you like to leave the co-pack on to have them come back?
I tell them to come back in 2 weeks, and if it falls off, it may fall off on its own, or it might still be there in 2 weeks. Whatever happens, let nature take its course. If it falls off, just ignore it. Don't look at the site. Pretend it was still on, and baby it. Or if it's there in 2 weeks, I'll take it off myself.
Yeah, I tell them the same thing. I just tell them to be really careful. Don't swish. Don't brush it. Stay away from it.
Yeah.
But when you're putting the that co-pack on, you have to have a top-notch assistant like you do that can mix that stuff right.
Yeah.
But also, I've used the syringe material where it's got the spiral in the tip and it mixes it as it comes out.
How'd you like it?
I don't like that.
No.
The consistency was not nearly as good for this procedure, I didn't feel. So I don't use that.
Sometimes the co-pack's a little firm. It's easier to lock it into the braziers. I don't know if you notice, if you do that too.
The other kind out of the gun is not as firm.
Yeah.
When you use the paquette knife to harvest the tissue, it's 100 times easier than doing it manually with a blade. And you periodontists are more used to doing that kind of stuff the hard way, but for us general dentists, we like to do it the easier way. And so when you first start using the paquette knife, one thing you have to do is get the blade right into the paquette knife. And so you basically break a razor blade in half, which is real easy. You just bend it and it snaps. And then when you put the blade into the paquette knife, you can the blade that comes out of the knife here, and then it bends kind of circular and goes back into the blade. So you've got a circle on the area you're going to cut with. That's not giving you the kind of piece of tissue that you want. So where the two ends of the blade come out of the paquette knife, you'd rather have it kind of squared off at the bottom instead of just bent around. Mm-hmm. So to get that square, you have to kind of hold it down and use your thumb and kind of bend it as it's in the knife and try to create that edge. And you will break that blade. Sometimes it'll crack because it's not made for that. And then you just put then you put the other half of the blade in. But it's important to kind of try to square off that piece coming out of the knife instead of just having the circle.
I always thought it would be cool to have a blade specifically for that are already squared off, and maybe like millimeter lines on it so you can measure. Yeah. I think that'd be really cool and convenient. Yeah, make it even easier.
Yeah. Yeah, yeah. If you had a blade that had that bend in them,
Yeah,
that'd be nice.
already.
But then they know it's for medical or dental purposes, and
And
they
they
charge you $1
charge,
million
yeah,
for it,
yeah,
which you can get regular blades at the store from with nothing.
yeah, yeah. That's true. That's a good
So,
point.
but
Yeah.
anyway,
So it's helped me a lot. It's increased the amount of referrals I get from orthodontists and pediatric dentists, just because it's so easy to do on a pediatric patient. I can't imagine sitting there and suturing with an 8-year-old or 10-year-old that's crying in the chair. So to just do it completely sutureless with periacryl and Copac and have it be successful on a young kid has
what
been a total game changer.
what kind of post-op instructions do you give them as far as the palate?
So I actually, for a pediatric patient, just because speed is important, I don't do anything for the palate. No stent, no PRF. It just adds more time in the chair, and for a pediatric patient, you have to be fast. And kids heal quick enough. Just tell them it's going to feel like a bad pizza burn, and to just baby it and be on a soft food diet. And the parents are usually compliant, because I always say, if they don't follow instructions, we're going to need to do it again. And then the kid's really compliant.
Right.
Yeah. But, I'd say maybe more than half of the pediatric patients, the Copac has fallen off that night, the next night. Sometimes the teeth aren't erupted enough to have embrasures to lock in the Copac, and so it falls off, and you're totally relying on the periacryl, and it works.
Right.
It still works every time. It's unbelievable.
When on an adult, how long do you tell them to wear the mouth guard
So
on the palate?
now that I do solid PRF without sutures, I tell them to keep the suck down in all times for 2 weeks. It's for comfort, and to rinse it out after every meal. Because it makes them a little bit more compliant with their diet too. When they have the suck down in place, they're not going to want to bite into a burger when they have the stent in place. So if they think they have to wear the stent for 2 weeks, then they're going to control their diet much better. Also, one of the variations, it's already an amazing technique. When you taught it to me, it was a paradigm shift. It was mind blowing. And then you take an unbelievable, great technique, and PRF has just perfected it. Because you can take the free gingival graft and soak it in liquid PRF, and it'll start to clot on the intaglio surface, and you'll have concentrated super physiological dose of growth factors on the graft itself, which will expedite healing. But also you can leave it on the tray, and you can cut the solid PRF to the exact shape that you need. You have your template, the graft itself. There's no better template. You cut the exact piece you need, you put it right onto the palate. And you do that right away by placing the solid PRF on the palate. It helps with the hemostasis during the procedure. So the palate will start to bleed less and less right away, because you're putting a blood clot there. That will intervene with the palate and start to become the clot that you need for the palate.
Yeah, the PRF really accelerates that, and that's really helped bring the whole procedure a long way. Since we have that before, you really have to wait for good old-fashioned slow Mother Nature to start the healing process up there. But when you've got something to accelerate that healing, like the PRF, that really
Helps.
it makes it a lot easier.
Yeah. How long have you been doing the sutureless technique now?
Well, I guess it's over 20 years, because I've been in this office about 23 or 24 years now.
Yeah. And you've been doing that technique alone in this office.
Yeah.
Yeah. And it's a success every time.
It's amazing procedure. It's always a success.
Always. It's more predictable than implants or anything else that we do.
Yeah, it's really, I mean, and it's such a good service, because when a lot of people, if they don't have very much keratinoid attached tissue or whatever, and they're getting recession and they're real thin, and the majority of our cases are on the mandibular anterior area, and if you have dissected cadavers or anything like that on that area, you can't afford to lose bone down there. the bone over those mandibular anteriors, over the roots, sometimes it's non-existent already. And I mean, if you have a millimeter thickness of bone over those roots, that's a lot. Okay, and you rarely have that much. And so by having some good keratinoid attached tissue over there, that type of tissue type really maintains that bone.
It increases the longevity of those teeth.
Yeah.
And losing your mandibular anteriors is a restorative nightmare,
Yeah.
replacing those.
Yeah.
So,
You know, you don't appreciate it sometimes until you've done some of these grafts, but when you do some of these grafts down in that area, and you realize when you reflect back, and you do when you're split, in some areas we do a full thickness, some areas we do a split thickness graft, and when you retract that tissue back, and you see the bone or the lack of bone, over
you see
those
the roots.
anterior, roots there, you're like, whoa,
Yeah. Well, good thing we're doing this.
Yeah.
And you see the follow-up 20 years later. So you
Yeah.
see them maintain those teeth, hold on to
Yeah.
those teeth. So you see the difference between the
Yeah.
patients that have received the free gingival grafts versus the ones that haven't.
Like that graft I did, I don't know, whenever it was, 15 or 20 years ago, and that you harvested the piece from just now and today and put it on the other side. That there's no way that you could get any recession over on that original side.
No way.
There is such
There's
thick,
no way.
fibrous,
Yeah.
firm connective tissue there that you could just beat on it all day with the hardest brush you had, and you just not gonna get any recession.
Yeah, exactly.
Yeah.
And you see patients all the time. They come in with all mucosa in the mandibular premolar area, and it's hard for them to brush.
Yeah,
because it hurts.
Very sensitive.
On the mucosa, especially around implants. If you don't have any attached tissue around implants, they're not going to do their home care around it. I don't care what they say. They're not doing it right if they have all mucosa.
I mean, there's all kinds of studies in the literature that speak to the maintenance of the crestal bone, how dependent it is on having good, firm, tissue, soft tissue around it.
Yeah. No, and peri-implantitis is one of the hardest things that we do. It's one of the hardest things to treat. And if you look at the literature, all the different philosophies, they treat it with some type of autogenous tissue, whether that's a connective tissue graft or free gingival graft. You can look at Frome, you can look at Amandine Pera in France. You can look at Alberto Mondri, he does a big free gingival graft around the areas. They all treat it with soft tissue, with adding keratinized tissue around the implants.
Right. There's really nothing else to do. That and PRF
Well, they all have different decontamination methods of the implant surface, but that's the one thing they all have in common, is they address the soft tissue or lack of soft tissue.
I don't think there's any real good way to decontaminate inside the threads and all that of an implant before you do something like that, except with an erbium laser.
Erbium laser is great. You can't use the Nd:YAG laser.
No.
Kotsakis has, some studies, and he's kind of pioneered the philosophy of just using saline, which has worked for him. I've had a few successful cases and a few not. It's just peri-implantitis is hard to treat, but you've got to address the soft tissue if you're going to address it at all.
Yeah. Peri-implantitis is hard to treat.
Yeah.
You got to. The main thing to do to be successful is to prevent that from happening.
Yeah. Yeah.
That's why it's ideally you want to improve the soft tissue before you do the implant, or before you do a lot of these things.
Or before, if you've got a real ridge deficiency in the posterior mandible, and you're doing GBR and you've got all mucosa, it's a much harder procedure. If you just do a free gingival graft on the edentulous ridge, it's going to be way easier of a procedure.
Yeah.
Your sutures are going to be more stable because you're suturing in keratinized tissue, and you're going to have a better outcome overall.
When you're doing any kind of surgery, whether it's implant placement or periodontal or anything you're doing, and you've got some nice, good, firm, keratinized connect tissue around there, it makes it so much easier, and you just know it's going to work.
Yeah. 20 years and no complications.
It's amazing.
So what did you call it? Stupid, simple, sutureless free gingival grafting. That's all. That's what it is.
It just works so well. It's so easy, and it's a real good income source for your practice too.
Yeah.
And and then it's the kind of thing where they'll notice it in their friends. I mean, you know, when you've got real receding gums, and so your teeth look about a mile long, and I mean, a lot of procedures you do, you bring up the tissue to do what you're doing, and then you either have a very shallow vestibule, or you don't have as much or enough keratinized tissue remaining where it should be. So, and you can see that on people.
You know, you said productive. It's been a huge production boost for me, just because you could shorten the amount of time that you need for it. But also when I do the in-office trainings, you know, usually they want to learn PRF, extended PRF, how to use it in soft tissue for recession coverage, etc. And everybody gets more excited about the sutureless free gingival grafting than anything else. And because it's so easy and it's not technique sensitive, it's easy for them to adopt it into their practice. And when I hear back from them is that it's been the #1 production boost for them. It's been the biggest takeaway from the training. It's just helped them increase the production of their office right away, because it is, you know, very simple. Especially, you know, if you use blunt dissection and you turn the 15 blade around,
Right.
You're not worried about any type of anatomy. You're not worried about the mental foramen, because you can see it and you're using blunt dissection.
You do that a lot better than I do. When I used to do that, and the way Miss used to teach it back in the olden days, was to use the Metzenbaum scissors and go in there and to spread, because they have the rounded end, so they don't have any point at the end, and just work in reverse to spread the tissue.
Yeah.
You know, so that's how I originally done it.
Yeah.
But just the procedure itself, and when you mix it with the mix PRF into the whole procedure, it just takes it to another level.
It takes it to another level.
So
Yeah.
that's a great thing.
Well,
I wish I could put PRF in my motorcycle or something, and see if it would help
See if it
that.
runs better.
Yeah.
No, but it's actually changed the way that I harvest connective tissue grafts. Because you can get, if you just take a round burr and you deepithelialize the palate, you know, you could take out a much meatier piece of connective tissue. You'll get a much better outcome of the site. And I used to not do that because of how much patients hated the palate. But now with PRF, I get way less complaints. So I might as well harvest my connective tissue graft that way and get a nice thick piece. So, you know, it's changed the way I do connective tissue grafts even.
Well, harvesting connective tissue is a difficult thing for a general dentist to do. That's more of a periodontist procedure. But I've watched you do some, and I'm like, boy, that looks a little complicated. But I know to you, you just act like, well, that's just all in a day's work.
Yeah. Well, it's a good technique, because, you know, even if your technique is great, because of the shape of the 15 blade, you're going to have rounded corners, and you're not going to get as meatier of a piece as if you harvested it like you would harvest a free gingival graft. You know, I don't care how good of a periodontist you are, how good you are at harvesting connective tissue graft. You're gonna get a thicker piece if you harvest it like a free gingival graft. You know, and deepithelialize the palate beforehand. But with PRF, you know, you can rely on patients having more comfort after the fact, easier healing, less complications. So I feel much better about harvesting my connective tissue grafts that way.
Yeah. PRF's amazing.
PRF's the best. The best.
We got to really thank Rick for all the work you've done on that.
Thank you so much, Rick. Let's talk about PRF, because I think we talk a lot about free gingival grafting, but now, you know, it's not about PRF.
We try to bring PRF as much
as we can. Yeah, it really is the best.
Yeah.
It changed my whole career. It changed my whole life working with Rick and working with PRF EDU. But when I came to this office, you were already doing PRF in your office. You were already doing facial aesthetics. Rick had been working in your office for how long? A year?
I think like 2 or 3 years? Or
3 years he'd been in your office already. Because were you using PRF before Rick came to your office?
I don't. If I was, it was only because of going to his courses. You know.
Yeah.
When I used to do a lot of Mish courses, and Mish used to also, spin blood. Okay. And but he or us or anybody didn't know nearly as much about all this PRF like we do now. And so it was very rudimentary the way that we did it back then. Because I'm talking, I don't know, 25 or 30 years ago. I don't even remember how long it was. It was a long time. And but he used to draw blood and spin it too and all that. But it wasn't nearly as refined as how Dr. Myron is. Knows the concentration, of the platelets and all at the different levels.
It's a whole new level.
Of everything.
It's so much more.
Yeah.
So much more improved than before. And when I talk to my perio professors and my mentors in perio about PRF, they say the same thing that they say about lasers now. It kind of works. You get some home run cases, amazing results. Something, not every time, but now that you have cleaner tubes without silicone in it and horizontal centrifugation and all the things that we can do with it, it is predictable. It is. We get complete closure and soft tissue healing every time. It's
so good. And doing the facial aesthetics that we learned from Dr. Myron with the PRF, when we do combination of lasers and PRF, and the microneedling with it, PRF injections. We use the liquid PRF. And you can use it as a filler. So you've got a biofiller instead of a synthetic filler that slowly, you get any kind of a regular synthetic filler, and they'll last 6 or 12 months, and they slowly leach out, and then you just got this basically poison leaching out in your body. Whereas if you do a PRF biofiller, it's still it'll make PRF, instead of it lasting 2 to 3 weeks, it maybe will last 4 to 6 months. And then when you heat it and prepare it like that.
But it's gonna release growth factors.
Well,
over
the good thing is, I would say,
yeah.
besides the fact that it wears away, you're stimulating neocollagenesis and collagen formation while it's in there.
Yeah.
And then when it does leach out, it's from your own body anyway already.
Right.
There's nothing else in it. But yeah, you're stimulating new collagen formation.
And it reaches a whole new market of patients. I would never let someone put Botox in my face. Me being
I wouldn't want any kind
I wouldn't do it. But if someone said, "Oh, I'll inject your own blood. I'll inject PRF," I'd say, "All right, yeah,
right,
it's fine."
Yeah. You have to explain to them that if somebody goes and gets a filler in, when they walk out of the office, it's full. And when you use PRF, you don't get that kind of results as much, although you can get some increase right away, but you're stimulating collagen growth. So it takes a while to go through that collagen cycle. And that's why when we do some of these facial aesthetics, we start off with 3 treatments about a month apart, because that's about how long the collagen cycle is for that collagen to form. So using the lasers and the PRF, you're stimulating that collagen formation, and it takes about 30 days, 28, 30 days for that to really materialize to its maximum. Then we do a second treatment, and then another 30 days later we do a third treatment, and we get a really good result that way.
And do you notice when patients come back because of the neocollagenesis, they look better each time, whereas with synthetics they may not have that?
No, yeah, you're right. And I remember this one patient we had, has been a patient for years, came in the office one time, and she literally almost ran some of my patients that were in the waiting room away. She came in, and I was happened to be standing right by the front desk, and she walked in, Dr. Kanter, oh my face, oh my God, I can't believe it, this and that. And the patients at first were like, well, you know, like, what'd you do to her face? And then she finally said, oh God, it's the first time ever my husband started saying all these positive things about me. He's so happy. Thank you so much and all that. And then they calmed down. But at first, the way she came in, her name was Lisa something. I can't remember. But it was funny because, I mean, the other patients that were in the waiting room were like, what'd you do to her? You know, and then she got the good part, and then they're okay. You know? So it's something that builds up over time, you know.
Yeah, that's funny.
It's a good thing.
You know, I was introduced PRF by you and Rick together when I came here for an interview, and you had me do a working interview, and that poor guy. I'm just kidding. And you know, that was really the first time I had used PRF. You know, I used it maybe once in residency. It's a shame that I didn't do more, honestly, because it's such a game changer. But it was a whole different procedure, you know. The bone graft was different with sticky bone. We used solid PRF over the membranes. It was all new. It was like I did a totally different procedure. And then I actually saw the results later, and it was like the 2-week post-op looked unbelievable. It looked like a 4-week or 6-week
The
post-op.
socket grafting with PRF and the sticky bone and the membrane and the collagen and then the membrane over it. What a difference in the maintenance of the bone.
Yeah, that's a, you know, you can appreciate it the most is when it heals by secondary intention. You know, like a extraction socket or the palate of a free gingival graft, you know, because it's an open wound. So you can really appreciate how fast that wound closes. You know, an incision line or single unit implant, you know, maybe won't notice as much, you know, when it's primary closure. But with secondary intention, like, it is a total game changer.
Yeah, it's amazing.
It's amazing. Thank you for listening, and thank you, Dr. Kanter. It's been an unbelievable 3 years working with you.
It's been a pleasure having you, and I've learned so much from you in here doing it. And sometimes I'll just have some of the other doctors, I'll say, come in and just stand over his shoulder and just watch him, how good he is doing this stuff. And so thanks for being here and sharing all your knowledge with us. And it's been a pleasure, and I look forward to continuing to do it.
Amen.